Coming up today, strong faith and a strong attitude. Hear what it took to endure ovarian cancer, plus the vague symptoms that finally led to a diagnosis. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. The woman we're meeting today knew something was wrong with her body. She became her own best advocate when searching for the cause. And when she finally learned that it was ovarian cancer, she endured. Today, we are asking how. And there is a spoiler alert because it was indeed a mix of both medicine and mindset. So happy to have Tracey Edmondson with us here today, cancer-free.
Yes.
Nice to see you. So glad you're here. You're going to tell us what it was like to find support during this obviously very, very scary time in your life. We're also joined by her surgeon, oncologist, Dr. Melissa Havliana, gynecologic oncologist here at the University of Kansas Cancer Center. We're glad you're both here to help spread awareness about ovarian cancer. So good to have you. We're going to learn more about your story, Tracey. So let's start. Take us back to those first symptoms that you were feeling, because we know they can be quite vague. You were seeing your primary care physician at another hospital. What made you go see your doc?
Well, I'm pretty good with knowing my body pretty well, right? And I just knew I was getting a faint tinge down in the lower where your descending colon comes, which is also the ovary area as well. But I had a faint tinge, little pain, and it wasn't consistent all the time. I mean, it would come and go, and I just knew, I thought, that doesn't feel right. That is new. And so knowing your body is a big part of it. It really is for me, and listening to your body. So I knew something was wrong, so immediately I made an appointment with my doctor, and my regular MD, and said, hey, you know, let's check this a little further. I'm not sure what this is. Let's check this out.
Very smart.
It's not right. Something's not right.
Well, especially since it was coming and going, and it's easily, it comes and it goes, and you forget about it. So very smart. You were getting a good thorough look over because they did a CT scan, a colonoscopy. What did they find?
So my regular MD said, you know what, Tracey, this is not really my area of expertise, right? So at that point, he said, you know what, I'm going to send you to somebody who's still in the same practice, but a general surgeon. And at that point, he was asking me all these questions about, you know, have you done your colonoscopy? Have you, you know, what's going on? And so we were answering. I said, no, but that was on the books, right? He said, well, let's go ahead and do the colonoscopy. I'll take a CT scan and we'll go from there and see what's going on. Let me see what's going on. So basically, they came back and said, well, you got two little spots that may be diverticuli or losis or whatever they call it before the inflammation. And then, but outside of that, there was nothing on the CT scans.
So you start treatment for diverticulitis. The pain is still there.
Yeah.
I was surprised, I guess, and others might be surprised to learn, you were told about this now cancer diagnosis while you were in the emergency department. What was that like? That is the last thing you're expecting when you go into the ER.
Right. Yeah, much to my surprise. Yes, so from there, since nothing was really found, except for the two spots that they suspected might be diverticulosis. Anyway, then what they did is they said, well, you know what? The pain continued on, right? And then it kept getting worse, right? So, and I was still not getting better. Well, what they did is they said, well, they suspected it might be diverticulitis, so what they did is they threw antibiotics at me and said, let's do this. Well, the antibiotics weren't doing anything. I wasn't getting any better. So at that point, I went in, I go, doc, enough is enough. I'm not getting better. And he goes, you know what? Go to the ER. Because if you go to the ER, he said, by the time I order all this stuff for you and get it ordered and get it out, time is wasting. He said, so I would rather you go to the ER and they'll just tell you right then and there what's going on, because they'll run the dye. They'll do all the stuff that you need to do to take a deeper dive into this.
So you eventually hear the words that you have cancer, but that's just the beginning. You need you need to know a lot more. And I love what your doctor said. This isn't my area of expertise, so let's get you to somebody who really has that. You needed more information. You had lots of questions. What made you decide to come to the University of Kansas Cancer Center?
So I have a great friend pool that they have connections. Well, one's a doctor here, a couple of them are nurses here, so it's like they couldn't say enough about how awesome. So then when I started, they actually gave me some names, the doctors, but they were on sabbatical or something. So anyway, it was meant to be. I ended up meeting Dr. Havliana, so there we go. That was the best thing ever. So through them is really where I came to KU. They said, if you want the best of the best, this is where you got to go.
Well,
right?
and sometimes, Dr. Havliana, we know we send people for second opinions if they would like one, and then certainly we are happy to be the second opinion, and that's how you came to know Tracey.
Definitely.
What were your thoughts about her path to this diagnosis? She starts by just knowing her own body, goes to her regular doctor, starts searching for answers. Is this pretty typical?
Yeah, unfortunately, ovarian cancer is a really hard diagnosis to make. So a lot of women have GI symptoms, or initially it's thought to be a GI-related process. And what's really challenging is with these symptoms, 90+% of the time, it is some GI issue going on. What's hard is to kind of sort out this limited subset of people who do have something else going on, especially something going on with the ovaries or something that turns out to be an ovarian cancer. So I'd say it's actually quite common that people are sort of bouncing around a little bit, being worked up for some GI issues, and we do see a reasonable number of women who do eventually end up in an emergency room just because things kind of keep getting worse, and they say there's something really wrong and I'm not getting answers fast enough, or this pain's reached a point where I need somebody to help me now.
Yes.
And I think that kind of sounds like where
That's
you got to, and that's exactly why you ended up kind of in the emergency room, and then they get routed through to us.
So let's talk a little bit more about those symptoms, those vague symptoms, because when we say pain down in this area, back pain, how do we know? And certainly GI. Most of us have some type of GI pain at some point, but how can we drill down a little bit more about what would lead us to get to a doctor and get some answers?
Yeah. So big things that we're looking out for, and this is kind of the same at the beginning, or when we're looking out for recurrences, are things like abdominal bloating, the inability to eat. So really, like you take a couple bites of food and you're just really full right away. Big changes with the way the bowel or bladder is functioning, and a lot of people do kind of have these like diverticulitis-like symptoms where they're getting some diarrhea, or they're kind of sometimes constipated and then getting diarrhea that's just not. People would be like, I've had some GI, everyone has some GI things that go on from time to time, but they'll be like, this is just something else than that. But that's why it's challenging, because the symptoms are pretty vague, and many people don't really have a huge amount of pain. A lot of people, they just notice their abdomen is getting bigger and bigger and bigger over time.
Big challenge is there's no screening for this. So how do we try to detect it as early as possible? I know you just mentioned it. Know your body, get to a doctor. Anything else we should know?
And that's one thing that I think there's a lot of work going on in this. I think we'll all be very excited when we eventually hopefully get something that we can use better for screening. So historically we've tried to use like ultrasounds and CA-125 levels for patients who are at very high risk, so patients who have things like BRCA mutations. But unfortunately, those haven't even been found to be effective in patients, who have these very high lifetime risks of ending up with an ovarian cancer. So if they're going to work in anybody, it would be that group of patients. So we are still kind of hoping to find a better tumor marker that perhaps could be used for early screening, but it's a real challenge right now to catch these early.
What stage was Tracey in? And did she have a certain type of ovarian cancer? We talk about breast cancer and different types.
Yes.
Is it the same for ovarian cancer?
It is, yes. So she had the most common type of ovarian cancer, which is high-grade serous ovarian cancer. So that accounts for about 70% of ovarian cancer. So definitely the most common type. And she did have some areas in the lung that looked abnormal at the start. So that was a stage 4.
How treatable and curable is something like ovarian cancer? And we know catching any cancer early is key, but as far as survivability and getting the right treatment, walk us through that.
So it is a challenging cancer to treat. We do have the good fortune that many people do respond well to chemo in the upfront setting. So there are some cancers like some other types of cancer where we don't really get a good chemo response even at the beginning. Fortunately, 80+% of people respond well to first-line chemotherapy, are able to get a surgery done. When we're able to get all the disease out at surgery, that improves people's outcomes. But really one of the biggest tools we have in our tool belt, which came into our tool belt, about 5 years ago, is PERP inhibitors. Which is a drug that can be taken in a maintenance setting, and Tracey's taking it, as I'm sure we'll discuss later. A drug that can be taken in a maintenance setting after we complete the upfront treatment. And that has made a huge difference, especially in patients with BRCA mutations, or in patients who have something called HRD, which is kind of a subset of mutations in the tumor that go along with BRCA or BRCA mutations.
So let's talk about that treatment plan, how you came up with it. You didn't come up with this treatment plan alone, is that what I understand? You have the board that helps really oversee Tracey's plan, and you get different opinions on what might be the best route.
Yeah, so for everybody, when we're initially meeting, we kind of talk about a plan to start out with. And for Tracey, I think she'd gotten one opinion about getting surgery first, and then when she and I met, we discussed doing chemotherapy first. Both treatment plans are good plans, and there are certain reasons why we might choose surgery first for some patients and then choose chemo first for some patients. The reason that Tracey and I talked about chemo is when she first came to meet me, she had a mass up in an area that probably would have involved removing part of her pancreas and her spleen and potentially a piece of bowel in that area. So obviously a bigger surgery. We do surgeries like that, but it's a bigger surgery. It has some additional risks that go along with it. And then also kind of some of the areas in the lungs that didn't look quite normal, which aren't something we treat surgically. It's something we really need the chemo for. So we kind of decided to start with chemo first, then got to her surgery, got all that final pathology from the surgery, and then after surgery, we review all of our patients at our tumor board, which is where we kind of discuss and make sure with all of the gynecologic oncologists here. We have a medical oncologist who also specializes in GYN cancers, as well as our radiation oncologists, which don't play a role as much in ovarian cancer, but still, are great people to have on board, for some other gynecologic cancers. And then also our pathologists and our radiologists are at the conference, so we can kind of look at the slides together, especially in cases where there may be something that's a little outside of the usual or expected.
So Tracey, that's got to make you feel good. You got Dr. Havliana there, and then you got this whole team of people behind her, backing her up and sharing their information. This must have been so much coming to you. What were you thinking as they were presenting some of this information and your treatment plan? You must have had questions, but felt like you were in the right spot.
Oh, yeah. Because, as I mentioned earlier, some of my friends, nurses here, doctors here, right? And so when they said that, they also mentioned the fact that, hey, you don't get just one doctor. You typically get a whole panel full. And I was like, wow, okay, that's even better, right?
Not a bad deal.
And as I came from one consultation with another medical facility, then I came over to Dr. Havliana and I said, I asked her, I said, why is the treatment plan so different, right? Why are they different, right? Meaning one said surgery right off the bat, and one said, hey, we're going to do chemo first and then surgery, and so on and so on. And so it made sense to me. As I was sitting there talking to her, I said, okay, now I understand. Now this makes sense to me. Let's get in there and let's do some shrinking first, because I was bloated. I was bloated. So even after the fact, I thought to myself, yeah, that was the perfect plan for me, meaning that, come in there, hopefully that, my body takes well to the chemotherapy, and it did, and it shrank a lot, and which enabled them then to do a better job as far as getting in and seeing what it was they were doing and what they were working with, as opposed to bloat and all, So, yeah, once I met with Dr. Havliana and her team, I was like, yep, this is it. I didn't even have to think twice about it.
All chemo, not created equal. Some guests have a okay bout with it, others not so much. How was your your chemo treatment?
Listen, she laughs because
I was going to say you're laughing now, but
Yeah.
Right. Unfortunately, I was one of the ones that at first got it all, right? And I love her and her team. They go, well, Tracey, you're just one of the fortunate ones. You get to have all the side effects. I go, oh, great. This is wonderful. But I will say this, as time went on, my body did get used to it. It did. And then it's like, okay, I can do this. I can do this. And with the medicine today and the technology is amazing. But yeah, of course I got sick, and the whole shoot and shebang was me.
lost your hair.
Yes.
You shared a photo.
Yes.
The before and the after. Look at you.
That was before. Yep.
But then you just took it all off in the driveway.
Oh yeah, because it was just much easier. Because, I was told, if after about your third or fourth treatment, you'll start to see hair loss. Well, I started to see it about second treatment, right? I was just one of those fortunate ones. But anyway, it was harder for me to see it laying on the pillow and all over the place than it was just to go, you know what, it's inevitable. Let's just go ahead and do this. And really, honestly, that was probably the best thing I ever did. Because then I was able to find some cute little hats and all kinds of fun stuff.
Well, that brings me to Missy's Boutique, which is such a great resource over at our Westwood Cancer Center. They have lots of wigs and all sorts of things.
Yes.
You settle on hats. You loved your hats.
Yes, because I tried the wigs, the synthetic and the real, and they were too hot for me. And I knew if they were too hot when I was standing in an AC unit, I thought, oh my gosh, if I get out and about, it's going to be too much. And it was for me. So for me, I settled on all the cute little hats, and they were so awesome to help me with, all the hats. And they're always getting new stuff, and I became friends with just
they're
everybody.
great. They're great.
Everybody down there at that location at Westwood.
Such a great group over there. You also had a cancer coach. Tell us about your cancer coach.
Yeah. So, I'm a big believer in, listen, not only is it a physical journey, but it is also a mental journey, and you need to feed that as well. So I just, again, reached out to, Dr. Avalana and her team, Ashlyn, and said, hey, where's some resources that I can, because I know you guys got lots, that I can talk to somebody who's been through this, who knows this. Because even though I have a great support around me, friends and family, I had no one who had been through it to talk to me through it and say, hey, you know what, that's normal. Hey, it's okay to feel this way. Hey, it's okay to, and so Nancy Park was, now we are really close. We're just best friends now. I almost feel like she's a sister of mine. So I reached out, Ashlyn gave me the information, I contacted, and they put me in contact then with Nancy Park, she said she volunteered for this program and wanted to help because she had been through it 5 years ago herself. And she wanted to help ladies.
No better person to sit down with than somebody who's been through it. Dr. Havliana, how great is it, though, to know that your patients, you treat them here, you do your part, but how important is it that they're reaching outside and getting the support out in the community and using those resources?
Yes, it's hugely important. So, I think obviously, like, we as a physician can give a lot of medical information. I think it's also great. We have a wonderful nursing team who have a variety of experiences. A lot of them have been like chemo nurses in the past. So again, just coming at it from a slightly different perspective. And then we also have this great program called the Women to Women program, which is, what got Tracey connected with her mentor. And I think that's super important too, and really just allows people to speak with somebody who's been through what they've been through, because I watch a lot of patients go through this, but I haven't been through chemo. It's very different. And I also think that everybody handles a little bit differently. Everybody has different challenges. So sometimes just talking about, like, this is what I'm really going through, and they may be like, that's not really something I experienced, but I experienced this. And I think it's also really therapeutic for the women who've been through all this to feel like, okay, I can kind of give back and I can share my experience and I can help somebody else kind of climb this ladder that I already climbed.
It's truly a blessing in both areas, and it really is.
I want to hear more about this support, but if you are watching live, be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is right there on your screen. So Tracey, it takes a village to raise a child. It takes a village to put your arms around somebody who's going through this cancer battle. Who's inside your village?
Many, many, many. My coworkers, obviously, my family, my friends. I mean, oh my gosh, I couldn't have done it without them. There is no way. By the same token, I feel like that Dr. Havalana, especially poor Ashlyn, who is her nurse, she got a lot from me, right? Listen, all of them are important, because I still to this day reach out to Ashlyn. And of course, we laugh about it.
I know we got nervous though when you stopped contacting us every Monday morning, when there wasn't a voicemail from Tracey every Monday morning at the start of clinic. We were, after you finish up treatment, we were like, "Is Tracey okay?"
No, it's
and
true.
it's like,
it's true.
Finally, we had to cut the cord eventually.
That's right. That's right. And I'm a huge communicator, so for me, it's like I want to know. It's okay to reach out. Listen. They were more than, they never made me feel like, no, don't ask any more stuff. You got to quit asking questions. No, never. And so, going through that journey with them, they became so important to me and almost like a part of family, because it's like, oh my gosh, And so there's times when maybe I struggled with something and I would just call Ashlyn, and all of a sudden I'm feeling pretty good about everything, right? It's just that mentor that just kind of says, it's okay.
You said cut the cord, but it is tough. I mean, when you have a connection with somebody who is helping save your life, there's something about that. It is a primal connection it's hard to let go of.
It is.
So I think you're stuck with Tracey for a while.
I know, we definitely are, but we're glad that you're not feeling like we have to.
Yes.
We're going like a month without talking to each other.
True.
As we were saying, we haven't
true.
seen each other in a while.
So
and it's sad, but it's also good.
Glad
That's
we could
right.
bring you back
That is
together.
right.
Yeah.
Birthdays mean a lot, always, but never more than after you've been through something like this. Tell me about your birthday here.
Yeah, that was fun. Because that was in January, and I still, obviously didn't have any hair. But the beautiful part about this is that I really think with the the research and everything that's been given up until today's date, that I worked through this, right? I lived a life. I had a life. I didn't have to give in to, you know, oh my gosh, I'm the cancer girl and that's it. I can't do anything. I have to sit in this house all day. No. And I tell you what, most of it's attitude. You have to take an attitude that's like, no, I can do this. I will do this. And I'll get on the other side. My friends helped me with that. They said, all right, it's your birthday. Let's go. Where do you want to go? And they dragged me out. Even if sometimes I reached out to family, friends, and neighbors and said, listen, you know, if you see me staying in too much, come over there, put me in the car, take me for a ride. I may be weak at that point, not be able to do much, but put me in the car so I can get out and see things.
You're not the cancer girl. I love when you said that.
I'm not. You know, it doesn't define me. It does not. It's just a rough journey that I'm going through right now, but I'll pass it.
So how'd you find that, though? You're saying that, and that sounds great, but it takes some, you have to really concentrate on finding that hope and the faith that you had.
Mm-hmm. Yeah, I'm a girl of faith. I mean, I believe, you know, I believe in faith. I have my higher power that I completely believe in, and I even shared that with Dr. Halana. I said, you know, I believe that, you know, that going through this, that God put me in the right place, right? And I said, and we even teased about it because the last four of her last name is my mom's name, Lana. Wow. And so when we got there, and Mom was with me, and I said, oh my gosh, it was meant to be. Look, your name is in her name. I said, this is great. So, you know, no, you know, I truly believe that it was a blessing and a gift. I was supposed to be a patient of hers.
Yeah.
And she was supposed to be my doctor.
Yep. So you guys are have this long-term relationship. What is Nexo for Tracey? I mean, is it just surveillance? What will this look like?
We're seeing each other every 3 months for surveillance. Tracey's also on a PARP inhibitor, so kind of like that medication we were talking about that works well for patients with a BRCA mutation, which Tracey has. So, you know, we are both working from the ovarian cancer perspective to keep things in remission as long as possible. You know, we're seeing more and more patients, especially those with BRCA mutations on the PARP inhibitors, who are potentially truly cured of ovarian cancer. So keeping a close eye on things that way, managing the PARP inhibitor side effects, which were a little bit difficult at the beginning, but we kind of got things to a place where it's going pretty good now.
Right, it is. It is.
And then additionally, getting screenings done for breast cancer and discussing, you know, prevention for breast cancer in the future. With our colorectal team, or with our breast cancer team as well, and then also kind of the considerations of issues with possible pancreatic cancer. So also talking with our high-risk GI team about that as well.
I always say it never gets old hearing the sound of that bell ringing, marking the end of treatment. What was this moment like for you, Tracey?
Oh my gosh, so emotional, so emotional. I mean, it's interesting because as I still drive by the Westwood campus, you would think that I would be like, oh, you know, it reminds me. No, I literally could go, hi, everybody, hi. You know, it's so interesting how that worked, but I really feel that, you know, going through that whole treatment, that it was just amazing, the people that were in my life at that point that just cared for me and brought me through it. And I felt that. I knew that. So when I was at the end and they rang the bell and all were standing there, it's like, oh my gosh, the pouring of emotion, you know, for multiple reasons, meaning there's an end, you know, to the treatment, yay, you know, but then again, I gotta leave you guys. You guys are a part of my family. Wait a minute, what? So yeah, it was a double fold for me, but it was really sweet. So
yeah, tough times in there, but some really good moments happened in there too.
Yes.
You took part in a cancer walk. What was it like connecting out in the community with these folks? Because this wasn't too long after.
This was done like my last treatment. It was right before my last treatment.
How were you feeling here?
That was a good week because actually I ran into the doctor and she goes, "Are you feeling good?" And I go, "I actually am. This is a good day."
I was a little surprised to see her out there. I was like, I'm glad you're here.
Yeah. And I said, you know, but again, I believe in pushing yourself. You know, you really have to. And yet still giving yourself grace and finding that happy medium between the both of them, right? Because you do have to listen to your body when it's completely tired and you need to rest. By the same token, you also need to push yourself out of, let's just say, I mean, there was days when my mom was sitting with me and I couldn't even walk, and she's 80 years old and she's walking faster than I am. But I said, Mom, let's go. So we both took a walk in the neighborhood. So, you know, you got to push yourself to a degree. You really do, because it helps the mental part of healing, which is huge. It's not just physical. It's both.
You're trying to get back to life. You're back to life. Your nails look fantastic, by the way, I must say. And I think you shared a photo. Was this you and your friend getting your nails done at the salon? I mean, priorities, Tracey, priorities, right? I love this.
Absolutely. Absolutely. You know, listen, I moved on with life regardless of what was going on with me. I tried everything I could to stay, and that's what's such a huge part of the mental health. So that was just recently where a friend of mine ended up, we didn't know we went to the same nail salon, and we do, and I was like, yay! So, yeah, live your life. Don't be defined by it. Don't be defined by it. And if you have to push yourself a little bit, push yourself.
Dr. Juliana, any promising treatments, anything nearing FDA approval that we can end our program today on? What's on the horizon, as they say?
So a lot of what we're working on, and it's across cancer types, are these new class of drugs called antibody drug conjugates. So the goal of these drugs is to identify a signal that the cancer is putting out that may be more unique to the cancer, so that as opposed to usual chemo that sort of affects all your cells, it's a type of chemo that may be more targeted to the specific cancer cells, and is able to deliver a type of chemotherapy into those cancer cells or into the neighborhood of those cancer cells that would be too toxic if we gave it to somebody systemically. So that's something that's definitely on the horizon as far as new types of treatments. There is one that recently received FDA approval, and we have some others that we're working on in our phase 1 clinical trial clinic here, and then of course across the country to try to help women, survive and thrive longer.
So we will see you back here on this program to share more. Let's answer some questions from our viewers this morning, and I like Jeremy's because he says this kind of cancer sounds like such a grab bag of frustration. I think that's a good way of describing it. It progresses slow, it's hard to detect, and there could be one of different versions of that, needing different types of treatment. Why is ovarian cancer so different?
I think that the most, like I said, the kind of ovarian cancer that Tracey had accounts for about 70% of ovarian cancers. And then the rest of it really is a huge grab bag. There are a couple different, larger families of ovarian cancer. The two other ones tend to affect younger women who are in their premenopausal years and behave very differently and have very different needs for chemo and everything like that. But they can have pretty similar symptoms because at the end of the day, you have a mass on your ovary, and that's really what a lot of people start getting the symptoms from, is that pressure and pain from that mass building up or fluid building up in the abdomen. So it is definitely a challenging type of cancer to treat.
Amy says, I know what menstrual pain feels like. Is that similar to all the pain that I felt during early stages of ovarian cancer? Would that be
So some women
similar?
can definitely experience, pain in the abdomen is always a little bit more difficult to nail down than pain on the outside of the body, and I think especially women's pelvic pain we could have the several hour-long program just about that, and also, definitely not my area of specialty, but it's a very complicated pathway that leads to women's pelvic pain, and women have pelvic pain for so many different reasons: musculoskeletal pelvic pain in the pelvis, menstrual type cramp pain, the pain of an ovary growing or changing, whether that's a malignant or benign mass. There are women who have masses that are, maybe benign, but are 30 centimeters in size, the size of a term pregnant uterus, who don't really even notice anything. And then there are women who have a 5 centimeter mass who really feel something, and it's hurting them. So that's part of what's really challenging to nail down. So I will say there are some women who kind of say, I sort of felt something that felt kind of like I was getting my period, or felt kind of like how I feel when I ovulate, for women who can feel ovulation. But there are also some women who really don't get any pain, even if a mass has grown quite large.
Makes it tough, which goes back to what Tracey said off the top of the program. Just really know your body and do not be afraid to ask questions and get second opinions. Doctor, what's the big takeaway from this conversation?
I think that feeling comfortable with your medical team is huge. These treatments can be hard to get through. Some people, we said the earlier program, kind of sail through this chemo. Some people really struggle. I think it's something especially that, working with Tracey, we learned is the PARP inhibitor is such a critical part of her treatment and really offers such a huge benefit to her. She was really struggling when we first had, you on this. You were like, I don't know that I can do this. This was the one thing that I feel like you came in one time and were like, I don't know if I can do this. And we managed to kind of find a way to work together to navigate through those symptoms, get her over the hump of that, and get her where she's now tolerating it pretty well and is able to do all the things she needs to do in her life. So I think just the importance of kind of working together with the team, communicating needs back and forth. And I would say some patients, Tracey is a wonderful advocate for herself and always lets us know what's going on. But there are some people that's really hard for them. And so I think that's also something that a family member, a friend, something you can do to be an advocate for somebody who maybe just isn't as, willing to talk to their medical team has a harder time, somebody who's like, I don't want to be a complainer. Sometimes a friend or family member needs to be the complainer for them so that we know what's going on, so that we can help
bring
make those
someone along
symptoms
for the
better.
ride to speak up for you.
Every time I feel like I'm like a broken record every time. I'm like, it's great to have a second set of ears on board with you here today.
Right. Well, and a lot of people go, I don't want to be that person that comes into the room and is trying to kind of butt into it. But I was like, no, butt in. Get in there.
Yeah.
Listen, ask questions for the person that you love. Tracey, do you have a message for your care team? Do you want to share anything?
Oh my goodness. There are no words. Besides, I'll start to cry. There are no words. I felt from the very get-go, even when I came in and was talking to the nurse navigator, she said, I've got this. I got you. From the very get-go. And that was the first person at KU that I even talked to at all. And I already felt, oh my goodness, as opposed to, as you heard me say earlier, they didn't return my calls from the last place. So, yeah. And then it was just nothing but straight care from there. I mean, the best care ever. And like I said, I still call, poor Ashlyn, I still call her quite a bit, right? But no, I mean, listen, there is no words to say how much I appreciate you all and what you do, and the biggest blessing ever for me. I can't speak anything negative. It was from the receptionist when you come in all the way through, everybody is so wonderful, so wonderful.
We know you're so grateful, and we're just really grateful that you're willing to share your story with us, because someone hears it and then someone goes to their doctor and steps forward. So thank you so much. Is there anything else you want people to know and take away from your story?
For me, personally, I think that, trying to carry that attitude of, I can do this. I really can do this. Is this hard? Yeah, it's hard. It is. But you have to really dig deep down within yourself, find your faith that that's, who you are, and really tell yourself, I can do this. And then the people that are around you, make sure that, they are positive, that they feed you positivity. Negativity is not what you need. So I am verbal. I shared with my family, let's don't talk about this. I have to live it. Trust me, I know it. We're all about it, right? But let's talk about everything else in life and just try to live as normal life as possible as you're going through it. But keep that attitude that you can do it. You'll make it through it. I mean, you will. You will.
So glad you're doing well. Body and mind. So thank you for sharing.
Yes.
Thank you both for being here with us today. We appreciate you. Thank you to our viewers for being with us. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update. When prostate cancer spreads, a new kind of treatment can seek it out and destroy it. I'm Jessica Lovell on the next Morning Medical Update. The radioactive particle that doctors compare to a heat-seeking missile, providing better life and fewer side effects. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.